As Cassie said, I'm actually the founding director of the National Center for Disaster Preparedness at Columbia, which is now part of the Earth Institute. And we also recently set up, and I direct something called the Pandemic Resource and Response Initiative. And that has obviously focused on everything to do with the pandemic since this all began back in February and March when we really first stood it up. But in addition to that, I've had quite a number of years of working on disaster response and written a book called Why We're Not Prepared for Mega Disasters, called Americans at Risk, and have also spent a lot of my career working on access to healthcare for extremely indigent and medically underserved children around the United States. And we have a network of 50 mobile pediatric clinics, and actually some of them have been actually deployed for various disasters over the last 30 years or so in the US. So yeah, I'm very deeply immersed in the disaster field and mostly focused on disaster policies, what we need to know, research that helps inform practice of disaster response, prevention, and mitigation. Of course, very connected to the predisposing factors that have helped create an environment where some disasters are really much more prevalent and much more awesome in terms of future threats to the United States. So climate change is one of those conditions, and large numbers of people who suffer from adversities and disparities here and around the world are also more susceptible to disasters. So it's we view this not as just something that we have to figure out how to respond to, but also how to prevent and what the larger context is. So this morning, I'm going to talk to you with you, and then because we want to do Q&A when I finish some formal remarks, but it's in two parts. The first is a general update or the status of the COVID-19 pandemic, and then we'll go into the specific issues on the impact of this horrible, intense crisis on education and schools and so on. So we'll begin, let's do a little screen share here. Participate in this session, and I think the interaction with people who are in the education sector is extremely important. I didn't say the education space because somehow there's something about that whole terminology. It's never very comfortable for me. I'm going to call it the sector. So, as I said, two parts: status of the pandemic, and then the impact on students, schools, teachers, and staff. And I just a reminder here, we're going to get to the school piece in a few moments, but the schools are more about buildings and more about the students. It's a community that is involved in a particular space, but it's children and it's adults, and the adults range from custodial staff to teachers, administrators, bus drivers, etc. And the concerns about pandemic are really across the board with all these individuals and all these various professions and support staff. So first of all, in terms of COVID-19, I think if you've been awake and listened to or read anything about the news with respect to the pandemic in the last even days, I think it's abundantly clear that we're in a really, really bad place. The trajectory for all the data about how bad this pandemic is getting, that trajectory is going basically straight up in the wrong direction. And we have to cope with that, and it's going to require some sacrifices and all of us going through some periods that may be very difficult. And I'm going to talk a little bit about how that actually gets managed. So I want to start with two columns of information. Column A is what we know, and column B is what we don't know. And what we know about this virus is, other than the data that we hear about every day, what we know about the virus, we do know that it's novel, meaning it's a new virus. It started in China. It's everywhere on the planet. it's infectious, it's highly lethal. It crosses international boundaries, which is why I'm saying it's ubiquitous, but it's one of the criteria for determining that something or designating something a pandemic. It's a new virus. It transcends the national borders. It could be transmitted from one person to another person, not just from animal to a person, and it could be lethal. So all the criteria that we need for a pandemic are met by this coronavirus called SARS-CoV-2 that causes COVID-19. The latest wave is out of control, and we'll get into some more detail about that. And the cases and fatalities will continue to rise in really kind of a whack-a-mole reality of, outbursts and surges, and then it gets quiescent in a particular place and it pops up somewhere else. No one really thought that Rhode Island was going to become an epicenter, but it may well be that in the next few days. One of the things that's new here, we got a glimpse of this in March and April into May, is that overwhelming numbers of cases that have to go into the hospitals are really threatening the integrity of our healthcare systems. We are at this point exhausting our bed capacity in many areas and have created a cadre of dedicated health professionals and hospital workers who are absolutely overwhelmed and exhausted, and hopefully just continuing to hang in there. We've used up pretty much all of the federal assets that might be able to help people in the health and hospital systems, but it's a very bad situation. Like I was mentioning about the schools, I want to say this about the healthcare and the hospital systems. We're not just talking about doctors or even doctors and nurses. The functionality of a hospital is dependent upon everything from admitting clerks to custodians to people that are in the nutrition department, therapists in terms of respiratory therapists, people that phlebotomists who draw blood, etc. The entire system is an interdependent array of professionals and staff support that are all critical to how the system functions. So when I say health providers, I really am meaning that the entire range of people that help keep the hospitals going. We are, of course, looking backward, and even right now, at a level of mishandling and incompetence by the federal government that is, there's no real words to describe it. I said this morning on MSNBC that I assumed it was a family news broadcast, and that I couldn't use the language I prefer to use, and I won't use it with you either. But I don't have the words to express how horrendously mishandled this crisis has been since the very beginning of dishonesty and mixed messages and fighting with health experts and so on. It's really extraordinary, and it'll be interesting to see how this is recorded in history. It's not going to be good. We also know that vaccines are here. They're actually here. I mean, they're here and going to be deployed in the UK shortly, and other places, other places in the West. And of course, there's the vaccines that have been developed in China and Russia. So vaccines are here, and they'll be literally here in the US within a matter of days. I will tell you that as of today, the number of vaccine doses available are far less than people thought they were going to be, unfortunately. When is the pandemic going to end? Who knows? Depends on how effective the vaccines are, how many people take the vaccines, and how diligent we are about applying the control methods. But in my view, it's very unlikely this is going to be over in some kind of real sense before 2022. I didn't have enough room here, so these are just examples of what we don't know. What we don't know about this virus and COVID and its future really outweigh what we do know. So I just want to run through a couple of things. So, if you get regular influenza and it's caught early, the doctor can prescribe something called Tamiflu, which can really mitigate the impact of the flu and keep you from getting very sick from the regular seasonal flu. We don't have an equivalent medication for pandemic for the coronavirus, but that's something that eventually we hope will happen soon. There are going to be challenges with vaccine distribution that we barely understand right now, but things like the cold storage for the Pfizer vaccine in particular are very extreme. There's many parts of the country that really won't be able to accommodate to that. We don't know yet really what's going to happen with potential mutations of the SARS-CoV-2 virus that causes COVID, but we'll have to see. We don't know how long immunity from vaccinations or even immunity lasts if you actually get COVID. It lasts for a little while. How long, we really don't know. Is it months? Will it be a year? We have to just wait and see. We also don't have a full picture of the medical impact of COVID. We originally thought it was a lung disease, which it certainly can be, but it's probably a vascular disease, and as such can affect everything from the brain to the heart to the gastrointestinal tract and so on. So there's actually clinics popping up around the country that are looking at helping people who have long-term impact from COVID, much of which we're just sort of, again, not certain where this is going to play out. Many, many risk factors make some people more at risk than others in terms of contracting this virus. It's very complicated. It depends on the risk factors you're probably aware of, meaning like if you're older person, if you have certain pre-existing conditions, lung disease, cancer, diabetes, and so on, you're going to be more at risk. But why some people aren't with the same pre-existing conditions is not known. The medical impact on it and the carrier capacity of children is something that's being looked at very closely, and obviously germane to those of you who work in schools. And this is also a pretty complicated question. We know that younger children may have presence of the virus in their nasal cavities, but whether they get sick at the same rate as adults, they probably actually do not. This is, again, especially true for younger children. Older teenagers behave like adults in terms of their ability to get sick and to spread the disease. And we don't really know what the best practices are for schools. It's been a dominating factor in the news about schools closing, schools opening, but we really are still groping our way through this, and we don't really have all the answers yet. As of yesterday, globally, more than 62 million confirmed cases and nearly 1 million fatalities, surging in various parts of the world. But in terms of surging, the United States really leads the pack. It's just extraordinary. This has to do with what I was referring to earlier in terms of very, very inadequate management of this. And I mean, if we had, done what Germany has done, there are 80 million people there. They've had 18,000 fatalities since this began in Germany. So if we had done what Angela Merkel had done in Germany in terms of leading their country's pandemic response, instead of us having now 380,000 fatalities as of yesterday, we could have kept it to about 75,000 if we had done what Merkel and other people in other parts of the world have done. And that's the global picture. It's pretty horrendous. In the US, we've had 14 million test confirmed cases. The reason I say test confirmed is that it means that you've had a positive COVID test. There are many, many more than 14 million who have clinically established COVID-19, maybe as many as between 6 and 10 times that 14 million number. So there's really a lot of Americans who have been exposed and who are infected. The fatality rate also, like I said, as of yesterday, 280,000 people have died of COVID-19. I say underestimate with a question mark, because a lot of people have died that were not recorded as COVID deaths. For example, in some jurisdictions, if the person died, even if they were clinically very clearly COVID situation, and they didn't have the test done to confirm it, they would not be counted as a COVID death. That's one category of undercounting. The other thing that's actually interesting, I know this will make sense to you, but at the peak of the outbreaks, wherever you are, so let's say you're in New York in end of March and into April, and you were having chest pain. You did not have COVID, but you were having chest pain or something else that was difficult, and EMS finally gets to you. And they don't think you have COVID, but you're having chest pain, you may be having a heart attack. Well, the hospitals are filled up, the ERs are overwhelmed. And by the time you get care for your non-COVID, but highly threatening disease, it may be too late to save you. So these we could consider to be secondary consequences of this disease, which has to do with overwhelming our healthcare system, crowding out our ability to do healthcare for others. The surging states here, I mean, you know, it is a constantly changing dynamic, and we do have lots of issues where, as I said, this is kind of a whack-a-mole reality. So a week ago, we didn't see that much in Rhode Island. Now we're seeing it. It's coming up as one of the main outbreak states in the United States, Rhode Island. But South Dakota, North Dakota, and all these others, and really many others. There's around 40 where we consider this to be a serious outbreak and serious surge. And obviously that's a huge burden on our healthcare systems and our communities. And it's really pretty scary if you happen to be living, which you could be at any moment, in a COVID surge environment. And by the way, there's no state that's not having at least some cases every day of COVID. Some are just more than others. The global picture, it's an interesting map to look at. You know, the dark purple are the high prevalence countries as far as COVID is concerned. And, you know, the US, as I said, leads the way, Kazakhstan, Turkey, and other places. But actually now in Spain and France, and Italy in particular, we're seeing big outbreaks. But if you look at the Southern Hemisphere, in Africa, Brazil is obviously a high impact area, but a lot of the reporting out of some of the African countries and countries in Southeast Asia has not been so rigorous. So we're not getting a picture really of how severe this is, but it's pretty intense. We just don't have the numbers to discuss specifically. The US maps that look at prevalence in various states, it's very distressing. This is the COVID impact on the US, and it's a serious problem. It's ubiquitous now in the United States. And we have a lot to think about because, by the way, when it gets to a level of prevalence like that, some of the tools we use to control the spread of the pandemic are no longer useful. In other words, you get to a certain level of prevalence in a particular community, and then contact tracing is not useful. Contact tracing meaning when somebody tests positive, we go looking for the number of contacts and who they've been in contact with over the last couple of weeks. And I think there's a misconception that we're now still looking to try to figure out where this started from. What event was it? It's very difficult to do that now with contact tracing. So now we're more, whatever contact tracing we're doing, and it's way less adequate than we would hope for. But what we're seeing is it may help us identify people who might be at risk, because if you're positive and you have been in contact with X number of people in the previous week, we want to be able to advise those people, have them get tested and so on. So the contact tracing as a tool for determining where outbreaks have been happening, not so good. As a mechanism for trying to advise people that you've been in contact with somebody who came down with COVID, that's much more useful. But even then, I think I'd be surprised if we have more than 50% of the number of people we need around the United States to do adequate contact tracing. Here's just some more data. You see here, this is new cases, hospitalizations, new deaths, which actually just took a big spike yesterday. And this is end of November at this point, is November 1st. December is already proving itself to be a particularly wicked month. January is going to be horrendous, both because of residual new outbreaks from Thanksgiving gatherings, much exacerbated by what people are likely to be doing for the winter holidays of Christmas, Kwanzaa, Hanukkah, and so on. Those are the times when people get together a lot. They travel, and we traveled a lot actually around Thanksgiving. And the spike we're seeing now is thought to be directly related to that reality that most people, or many people, did not heed the warnings of the CDC and other agencies to stop traveling. What a sad state of affairs when there's been such undermining of public health authorities and evidence-based policies that people don't know what to believe. And plus, it's really overwhelming in terms of getting together with family and friends around the holidays. It's extremely difficult to resist that. And but like I'm going to conclude this talk in a little bit. It's really essential. This is about saving lives. There's no other way of putting this. We now have a situation where COVID is the third highest cause of death in the United States in adults. So it's heart disease and cancer, and now COVID. And nobody would have imagined a situation like this a year ago. But here we are dealing with this terrible reality. We talked about that. We're now averaging this very striking number of 1 million cases per week and over 2,000 deaths a day. And we've been seeing 2,500 to 2,800 on several days in the last week or so, and which is about what we lost on 9/11. So you can imagine, this is like, from a fatality point of view, this is like having a 9/11 every single day for the foreseeable future. And that's pretty awesome, pretty scary, but it is what we're trying to deal with. And why the public health messages are getting so strident is because we're dealing with a lethal threat that's popping up all over the country and getting more intense. This point about hospitalizations is of particular concern to me. I mean, it all is, but you think about it, we now have way exceeded the number of hospitalizations that we saw in the spring. We have 100,000 people approximately in hospitals across the country. And that's significantly higher than the 60,000 peak in the spring and summer of earlier this year. But the rate of rise of hospitalizations is also striking and deeply concerning. We're talking about doubling the number of people coming into the hospitals over a month, in the period of a month, and tripling since September. And 20% of these hospitalizations being admitted to intensive care units. So I don't know where this is going or when it's going to end, but right now it is putting fantastic stress on our healthcare systems. This is about the events or situations that we call super spreader events. So what is it that causes these to happen? I refer to them as tinderbox accelerators. And like, where do we have this, the cause of these persistent upticks and surges? College campuses, probably 300,000 US college and university students have tested positive, including, by the way, my 20-year-old grandson at Ohio State University. He didn't get sick, but he was positive and had some minor symptoms, now better. But college campuses are a breeding ground for a variety of reasons that you can probably imagine. Indoor restaurants and bars, clandestine parties that are happening. There's a report in New York Magazine recently about people throwing these parties with lots of guests, at sort of secret locations in various parts of New York City. It's happening all over the country too. Second group are the holiday celebrations, which I've already mentioned: Thanksgiving, the winter holidays, and other large gatherings. And the third group of tinderbox accelerators, large-scale events, especially without proper NPI. NPI means non-pharmaceutical interventions, NPI, meaning wearing masks, keeping distant, hand hygiene, and so on. And we've heard a lot of the news about religious ceremonies, evangelical churches, Orthodox Jewish weddings. There was one with 7,000 people, unmasked individuals participating a couple of weeks ago. Trump rallies have become a classic case of an out of control, reckless gathering of people pushed on by the president and attending these galleries shoulder to shoulder. Most people not wearing masks. Those rallies are over, but the Trump White House is planning 20 Christmas parties, for this holiday season. And it's just the height of irresponsibility. But you get the picture here. This is a very inappropriate time to even talk about such events. In fact, there's some pressure now for Joe Biden's inauguration to be as virtual as possible. We'll see what happens with that. And then the other accelerators could be people that are living or working with other individuals around, but in closed environments with not necessarily great ventilation. These are situations that can really cause folks to get sick. So as I mentioned earlier, yes, there's a lot of pandemic fatigue, but I get that. But it's time to wake up, drink another cup of coffee, and you can't let the fatigue overcome better judgment, because what we're dealing with is fatigue versus fatalities. So if you're too tired or too exhausted or too depressed by what we have to deal with, and you want to let down your guard, you should be prepared for more fatalities, especially in your own personal circles. And this is a problem, and something that hopefully, adults in society, even as an example to our children, we have to hang in there. I mean, there have been horrible situations that the world has had to put up with, including world wars and the Great Depression, the Dust Bowl, massive disasters with slow recovery. This is our time to kind of have to step up and hang together and hang in there and make sure that we are not violating the public health recommendations, which are so critical to keeping this situation under control. The tools we need to really combat this, first of all, we need more and better drugs that take care of people that are very sick in the hospital, and we are making progress there. These tools are going to be, in my current estimation of chronologically, when they're going to really appear in full force. So we already have hospital drugs, although this morning there was a report out that remdesivir, one of the drugs that had been approved for fairly widespread use in sick individuals with COVID, that the NIH is pulling back on when they should actually be used. So we'll see where that goes. Vaccines are on our doorstep. There's a whole other discussion we could have about how soon will they be ready for mass distribution and actually get people vaccinated. It still remains, if we're lucky, in the second half of 2021. In the meantime, the first tranche of these vaccines will be delivered to frontline healthcare workers and highly vulnerable senior citizens, especially in congregate environments like nursing homes. PLC, point of care testing. We need to do 20 to 30 million of these tests a week at least. And in some environments, they need to be daily. And when I'm talking about point of care, we mean it doesn't have to go to the lab, but there's a little strip like a blood sugar test or a pregnancy test that you can get a result from a nasal swab or saliva in minutes. And 20, 30 minutes, you'd have a result. And there are many environments where that should be happening regularly. Consistent evidence-based national policies. We have 45 days, and the new administration will come in, and I think we'll see a shocking change in how this entire crisis is being approached. Sorry, we got a little stuck here. Let's just see what's happening. Cassie, are you there?
Yep, I still see your screen.
All right. Okay, let's see what we got here. Okay, and then the fifth step is outpatient drugs. So like I was saying before, if you get seasonal flu, doctor gives you a prescription for Tamiflu. We're looking for those drugs that will deal with COVID-19. And the ones that are asterisked here, these are the ones that are game changers. vaccine, regular point of care testing, and these ambulatory drugs are the things that are going to make a real difference. And if everything goes as hoped, we'll be in a much better position to control this. So I want to move now into issues around the schools, what we need to know. And first of all, there's a few data points. I'm going to focus on the US, but this is absolutely not concerns that are limited to the United States. Is probably closer to 2 billion children now that have been out of school or don't have child care access because of the pandemic. And the implication, especially for developing countries, of this is overwhelming. 90% of countries implementing remote learning policies, and I'm sure we'll have some questions about that. But millions of children, hundreds of millions of children, are going to be suffering very long-term consequences from discontinuity of their education. There are a lot of different ways of approaching this. There's a lot of countries in Europe that have taken a different attitude, and mostly the most dramatic differences are some countries that have been strict about closing and locking down businesses and restaurants and bars and gyms, but have been able to keep their schools open, and they're doing okay, really. We have many places here where schools are closed and the restaurants remain open. This was true even in New York City. It's still true as we speak. So, Cassie, could you just, okay, never mind. School closures due to the pandemic, or we don't know how many children are actually going to be affected, especially affected for the long haul. But we have over 55 million kids in U.S. schools, pre-K through 12 in the United States. And overall, we're really worried about really impairing the learning and developmental course for many kids. We're seeing very extreme disparities that apply to various racial and economic conditions. And I think we're still looking for the tools to measure the educational outcome for some children that have suffered these disparities. And that's data that we're trying to develop as we speak. Disrupted access to special ed programs for children. These are vital programs that kids are not getting. And of course, they're not going to school, they're missing the social interactions, which are so important to social and emotional development. So, which children are at highest risk or at high risk for consequences of educational disruption? And these have to do with, so first of all, the huge number of children, especially Black and brown kids and those living in poverty, who were struggling before the pandemic even appeared. All of their struggles are exacerbated now. The loss of the totality of support that's given to children in school by their teachers and other support staff is incalculably bad. There's much more than learning to read, write, and do arithmetic that happens in the school environment. And good schools, good teachers, and administrators know this. But the loss of that overall support from their teachers is a big deal. Many children are, when they do go to school, even if it's in a hybrid, remote plus in person, are going to be traumatized because of what's going on in the country. Many children who are grieving will be suffering greatly, and teachers need to be aware of and supportive of helping children deal with big loss. A study out of Penn State University a couple of months ago showed that for every death in an adult, there are 9 people left behind grieving. In New York State, there were 4,200 children as of 4 months ago that lost a parent, which is enormously traumatic for children, as I'm sure you all know. More food insecurity in schools. The more children are hungry, the less they are able to concentrate and perform in education. A lot of children, we're about to launch a big national study on this, but lack access to remote learning tools or support for learning remotely. And we're also seeing a rise, of course, because of job loss, rise in poverty rates, family stress, domestic violence. So this is the context of children who are at particular risk. Additional consequences that are even more specific here, just a little bit more information, but because kids are not getting access to health care as readily as they did before the pandemic, there's studies that have done, this one by Blue Cross Blue Shield, suggesting that 9 million vaccine doses for the regular childhood vaccinations, measles, polio, and other diseases have been lost and missed. There's actually 30 million kids who are dependent upon, in the United States, who are dependent on free and reduced price lunches and breakfasts in schools. And that, of course, is a very difficult situation. And the loss of daily contact with teachers, which I already talked about. So I'm sort of thinking about this and why I put this slide together. What, if we wanted to say, what is a pandemically safe school? What do you have to do? What do you have to be aware of in order to make sure that children and staff and teachers are as protected as possible during a pandemic? So first of all, younger children are not anywhere near at the same level of risk as older children and adults, which I mentioned earlier. So the younger, that means for elementary schools, that's a relatively safer population of children in the schools. If we can make sure that teachers and staff who have particular vulnerabilities to getting infected with COVID, meaning that they may be older, or they may be overweight, they may have pre-existing conditions, as we mentioned before, it'd be good if those particular adults were protected and maybe not even participating in in-person classes. Ventilation in the classrooms is really important, or having classes conducted outside, even better, but obviously there are weather and seasonal constraints that affect the Northeast that don't affect Florida, let's say. Frequent testing is going to be key to monitor the situation. I believe in some number of children and staff should be tested every day, which actually would be feasible once we get those point of care tests that I mentioned. The school must be fully committed to operationalizing all of the non-pharmaceutical interventions. So no exceptions to masks, social distancing, one-way corridors in the schools, and appropriate numbers of places for children to wash or sanitize their hands. And then clear rules for the school and for the community about when schools open or close. And then really encouraging everyone to get vaccinated when available. And you probably know that there are a number of the companies that make vaccines that have just started on trials involving children. This is just some interesting data. This is the number of school districts, which is almost 9,000 in the US, that require or don't require children to wear masks. And as far as staff is concerned, the vast majority do require staff to wear masks. The question of schools, are they hotspots? Well, we've been saying that there's limited transmission and infection rates among young children. And there's some jurisdictions like in New York City where the mayor declared in the summer that since we had a very low incidence of the disease at that point, that they would keep schools open, at least on a hybrid basis, for those students and families who want to send their kids there. The threshold was a 3% positivity rate citywide. We reached that. Schools were closed. A lot of debate now between the state and the city governments about whether we should be looking in a more fine-tuned way at the number of kids, the number of people in the community have been positive. So in other words, if you have a high prevalence community, just focus on that community, not for the whole system and so on. So the situation in New York, because we're here, is that on Monday, the K through 5 children are going back to school, at least on a limited basis. And on the 10th, a few days later, we're going to see children with special needs special ed needs and so on are going to be going back. That's the schedule right now. And similar strategies happening in other large cities, Chicago, Philly, LA, etc. Once the vaccines appear and are available and drugs to treat people with low levels of COVID-19, that of course will also hasten our ability to bring children and teachers back to school. So I'm going to conclude with this slide because this is something, you know, it's not just because my mother was a sixth grade teacher for decades, but because I'm not sure we're paying enough attention to the concerns and issues that are on the minds of our teachers and staff, the people that are responsible for keeping the schools functioning, who have very legitimate concerns. So there's a number of questions here that somebody should be asking, which is, if you're a teacher, how are you doing? Not just your children in your school, but how are you personally and your families doing? How are you feeling? What are you worried about most? How can we respond most effectively? Do you feel that you have a sufficient voice in the policies that affect you and your school and the students? There's nobody more on the front lines than teachers. And it is really important that we make room for their voices to be heard as policies are being developed. I'm not sure that's happening enough. What do you need to know to help children who are grieving, who have been traumatized, who are trying to deal with this enormous disruption and stress? How do you do that? What more training might you need? What more information might be important for you to have? Do you feel safe and protected, you yourself, in the classroom? You look around, the kids may have masks, there may be partitions up, but you're standing there in front of the classroom. Are you feeling safe and protected? If not, why not? And what are we going to do to fix that? Are you personally struggling with remote teaching? This is, I don't know how many of you who are educators, when you went to school for your undergraduate or graduate degrees, how much you learned about remote teaching. But if you were trained, you know, X number of years ago, probably not much. Have you been given the right tools to help you become a really excellent remote teacher beyond just a classroom teacher? Are you getting enough support from your school, the district, the teachers, and the media? I don't really see quite enough, you know, doctors, nurses, and the healthcare system is getting a lot of attention. They should. But teachers are also heroically on the front lines doing invaluable work, just immeasurably valuable work to make sure our children stay on track. And then should you get vaccinated? We can discuss that now in the Q&A, but I think you should, but we're happy to talk about that. So let me stop there, Cassie, and let's talk about, let me just end this. Let's see if we have some questions that we can.
Yes, definitely. So we have two questions in the Q&A box. The first one from Diane, I'm going to go in order here. So the first one, is there any understanding of why some people who are highly exposed, for example, took care of an ill family member who tested positive, don't develop COVID and actually test negative?
Yeah, I mean, this is one of the things that I'm very interested in, is that susceptibility to getting the COVID and getting seriously ill from the coronavirus. There are internal factors, so your own immune system and how it responds, what it's responded to in the past. There are issues that have to do with how much exposure have you actually had. Are you exposed to very infected people for long periods of time? And are you wearing appropriate personal protective equipment? And do you have any of your own personal risk factors like we've been talking about, which is older age group, obesity, certain medical preconditions? So it's pretty complicated, and I don't think we have full clarity yet on that question, unfortunately.
All right, thank you. The next question. So from Connie, what is your opinion on the Great Barrington Declaration and the focused protection approach?
I mean, which is really about herd immunity.
Mm-hmm. Mm-hmm.
I think it's nuts. Can I be more clear about that? I think it's dangerous, stupid, and will cost even more lives than we're currently worried about right now.
So Irwin, maybe for those who don't, I'm not as familiar with it. If you could go into a little bit what it actually is, that might be helpful.
For what? For say it again.
For the Great Barrington Declaration.
Yes, the Great Barrington Declaration is kind of a formal statement from people who believe, including some scientists and doctors who believe that, in essence, let it just sort of run its course. We'll build up people who have immunity, and then that's a good way to control it. It's also a good way to kill a lot of people from exposures that that were unnecessary. And to deliberately expose people to an illness that has such high fatality rates associated with it is unspeakably bad.
Mm-hmm. Thank you for
clarifying.
clarifying.
The less inhibited I am about being clear about that.
Well, thank you for being clear. Our next question is from Tom. So he said that he's read that vaccines still need to undergo separate trials in adolescents and young children before approval for those populations. Will the timeline be delayed significantly from the availability of vaccines for adults?
Well, the vaccines for adults are going to be available very shortly, but the trials for children, especially the first trials for children, involve kids 12 to 17 years old. And I think that was Pfizer, and Moderna is going to do 11 to 18 or something. But those trials have to take place before it's generally released. It's a very interesting moral and ethical question about, if you're a parent, whether you're going to let your 11 or 12-year-old child be in a human trial. I think it's good that there's some people that are. I'm saying that, though, not certain that I would allow my own child or grandchild now get that. Not that I have any control over what my kids do with their grandchildren, but if I did, I don't know. I would actually. I don't know where I stand. I'd be reluctant, but on the other hand, the trials are going well with very few safety concerns in adults. It's a different kind of technology, so-called messenger RNA technology, which is probably safer for children than some of the other older technologies. So I have mixed feelings. At the end of the day, I'd probably give my thumbs up if my grandchildren were, in line to get to be part of a trial.
Mm-hmm. Okay, thank you. And from Anne, she writes that she's a 5th grade teacher in Bensonhurst. My students are doing well academically. I have the tools to teach online. I am to be back in the classroom on Monday. There are no shields. The children eat 2 small meals in my classroom with me. I'm in my 50s, and how can I personally stay safe?
Right. I think that the trick here is, first of all, congratulations to the work you're doing and your commitment. It's beyond important. And you stay safe by following these NPI, the non-pharmaceutical intervention guidelines. Very diligent about wearing a mask and a shield. If you're comfortable with that, that's a great idea. And keeping, strict adherence to hand washing and hand sanitizing, and making sure that you and the children are staying as separated as possible, and getting tested. Now, the quote unquote getting tested is not so easy right now in a lot of places, but hopefully it will be easier and easier even in the next few weeks. New York City is exploring all kinds of ways to get huge numbers of point of care tests available so that you can be really monitoring yourself and your colleagues and the kids in your classroom. But did you say the kids, Cassie, did she say the kids are doing okay academically, or she's worried? What?
They're doing okay. They're doing well academically, and she has the tools to teach online. Yeah.
Great. Fantastic.
Mm-hmm. Yeah. Great. TJ asks, how might schools tell high-risk staff and teachers that they aren't able to teach in person? What should that policy look like?
Right. So if you're high risk or relative, this is all relative. So if, let's say, I don't know, you're in your early 60s, a little overweight, you're probably a little higher risk. But if you decide that you want to take that risk with the appropriate precautions as we just talked about, then you should be allowed to. If you're, if you have lots of risk factors, you're, more than a little overweight, and you have diabetes, and you may have had emphysema or whatever else you might be dealing with, then you're at significantly higher risk, and you should not do that, not be in indoor spaces in classrooms. And it's all, the lines are all fuzzy between these various categories of risk. And I think we have to do the best we can to advise you that it's either pretty okay to work in a classroom or really more dangerous. And I personally think about this of, my mom was asking me at various points in her life, would it be safe? And sometimes it is, sometimes it isn't. So it's really kind of an individual judgment.
Okay, we're getting lots of great questions now. I'm going to do my best to kind of condense them a little bit. And there's some questions about whether or not you had advice about keeping or monitoring mental health of students while they're at home, and if there's particularly kids who might have ADHD or other challenges that they face when it comes to learning. And it's a lot also on the teacher's mental health to be witnessing or be part of situations that are not safe for their kids. So is there any advice around mental health? A big question.
So you're talking about kids who are at home, like learning remotely? Or
Yep.
Let's see, wait a minute, what happened here? Or are you talking about kids in classrooms?
Kids learning remotely at home.
Remotely.
Mm-hmm.
Well, this is really, really difficult, because if you were with the kids in the classroom and you can see where behavioral changes are happening, kids are falling asleep in class and not paying attention, they may be acting out. All these things would be indicators that something is awry. But communication with the parents, when you say remotely, I'm assuming you're talking about like Zoom sessions like this. And I think teachers are going to have their radar up in terms of children who may not be even on a Zoom call, not acting right, not responding, not asking questions, losing their attention, and so on. Those would be things that you maybe want to schedule a individual conversation with a parent and get some more detail. Are they sleeping okay? Are they having nightmares? Are they acting out? And all of those questions might lead the teacher to say to the parent, I think we should start with an evaluation by the pediatrician. Let's just kind of see if we can get a handle on what's going on. But it's really, really difficult. And these issues, which may never have popped up in a kid who was just in a regular classroom going on a regular basis, might well be happening in this crazy environment where everything has changed, and that might make them even more predisposed to having these kind of behavioral and emotional responses to stress. It's stress and trauma, and it manifests in different ways, different age children. And I think being aware of this, and I think maybe even correspondence from the schools to every single parent, this is what to look out for. Bad sleeping, nightmares, all the things like just loss of appetite, getting aggressive with friends and siblings. Those are the kind of things that it would be good to have that communication with parents about what to look for.
Okay, thanks. There's a question about contact tracing. So first, is there evidence that it has reduced the spread when it's implemented? And second, have we overwhelmed our capacity to do contact tracing with current infection rates?
Yes, to the latter. We've really overwhelmed our ability. It was never great to begin with. We've been chronically short of contact tracers, but this is a bad situation now. And contact tracing is actually most useful in the beginning of a pandemic or an outbreak, so that you can figure out where it's coming from and what to do about it, and isolate or quarantine people. So yeah, it's really tough now to try to catch up as far as contact tracing is concerned.
Okay. All right. And there's some questions about the vaccine. So has enough time gone by for the vaccine trials to show long-term effects on the body, to be comfortable with the safety of the vaccine? So many people are concerned that the vaccine was rushed and they don't feel that enough time has passed to be and dedicated to really focusing on the long-term effects.
So yes, I was among those who said this is really rushed, and how are we going to know if people start getting complications in 6 months or a year?
Mhm.
But with these new technologies, it's I think we're probably okay, and most of the serious complications would occur by now for people that have been in the trials, and we're not really seeing much of that at all. So it's hard to know exactly, but maybe this would help. I'd like to be first in line to get a vaccine myself. My own little risk factors and all that, I would get it, knowing that, yeah, what if something shows up in 6 months or a year from now? That's true. And don't forget, we're going to be vaccinating hundreds of millions of people. So the chance of having things happen either coincidentally or caused by the vaccine, it's always something we have to live with. This is, again, risk versus reward. I think the reward of being, getting resistance and immune response to the SARS-CoV-2 virus is worth a relatively small risk of something untoward happening.
Okay. Great. And just to follow up on that, because there's another question about the vaccine and specifically the mRNA technology that's being used in vaccines. Can you explain how that technology works? And this is coming from Cheryl, who's a 10th grade New York State living environment and biology teacher. And she would like to be able to explain.
Kathy, I think just repeat the beginning of that question.
Oh, sure. How would you explain the mRNA technology that Moderna is using in a way that students can understand, and this particularly for grade 10 students?
Right. So these technologies have to do with actually tricking the body. We take a little piece of the spike of the coronavirus and we inject that, and the body thinks it's the whole thing, and it develops an immune response. So we're not actually giving the virus to people. We're giving this little outgrowth of the virus. It's put in the body. The body says, "Oh, something bad's happening here. We're going after this," and you develop an immune response that carries over. So if you actually get the whole virus, the body's response can take care of that. That's in a nutshell, more or less what we're talking about.
Okay. Great, and I think we're going to have time for one more question, which I think is a nice way to wrap up the session. Is how might you suggest that we combat misinformation about the vaccine? There's people sharing all kinds of information out there that's just filled with errors, and people are believing them as fact. So I was
going to ask the audience how to do that. Listen, we've been dealing for years with this growing, intense anti-vax movement. People who are convinced by complete refutation of this concept that the mumps, measles, rubella vaccine can cause autism in children, which it does not. In a blanket way, it absolutely doesn't. But we haven't really gotten the tools developed that will effectively combat this misinformation. Of course, social media and the internet have been a treasure trough of conspiracy theories and inaccuracies about almost everything, and especially now with the vaccine, which is one of the things that's really very troubling, Cassie, because we're going to have these vaccines out there, and I don't know, maybe 50% of the population will be hesitant for legitimate and not legitimate reasons to take the vaccine. But if we don't get 75% of people taking the vaccine or have had the illness, we're not going to reach that herd immunity. And that's, unfortunate and really kind of a tragedy. But we have to be, it's not just facts. You can't tell an anti-vaxxer, oh, that theory has been debunked. It's not true. You have to get more into the dynamics of how people get fixated on a point of view that may not be based in facts or science. This is a much longer discussion, which I'd love to engage in. I'd love to, like I said, I'd love people in the audience may have far more to say that's useful than I do about the issue, but it's a big challenge. And a big challenge, by the way, for the incoming Biden administration.
Right.
All the plans that they might have, and they're really good ones, which I'm familiar with. One of the mysteries is how are we going to convince Americans that they really do need to take this vaccine?
Right. Okay. Well, thank you. There's another question, Steve. Actually, that question might be Actually, I'm going to keep that for our next presenter. So Irwin, thank you so much for your time today and for joining us. We'll be sharing the recording with everyone, and as well as Dr. Redlener's slides. So yeah, Irwin, any final sort of concluding remarks that you'd like to make?
Only to say that, I just want to reiterate this point about the heroes of our society. I mean, I wrote a piece in May in the Washington Post called The Pandemic Generation. Our children and the consequences, not just from the disease, but specifically about disruption of education, consequences are going to be felt for many, many years. A lot of remediation, a lot of focus, and a lot of determined mission about how to get kids back on track is critical. And we can't do it without the folks involved in teaching our kids.
Excellent point. So Irwin, thank you so much.
Pleasure, Cassie. We'll do it again.
Thank you.